Welcome to the Deep Dive, where we extract the most important professional guidance and turn it into immediately actionable knowledge for you. Today, we are facing one of the hardest challenges in any high-stakes environment: conflict. If you work in a clinical setting, you know the drill. It's fast-paced, high-pressure, with incredibly diverse teams. Disagreements aren't just common. They are, well, they're inevitable. But when tensions flare up, the risk isn't just a bad meeting. The risk is patient safety. So this deep dive into NHS and GNC guidelines isn't about teaching you how to win an argument.
No.
It's about providing you with a rigid, structured framework to make sure that safety and civility never drop when the stress levels rise.
And that's the critical mission here. We're focusing on structured, codified methods, frameworks that are proven to address disagreements promptly and fairly. It's about protecting the patient first and then staff well-being and workflow. Our goal is to give you the exact protocols that reward a swift, safe, and fair resolution.
So we're looking for a formal, almost algorithmic response to what feels like a purely emotional situation. Before we dive into the specific steps, what's the core idea here? If I'm highly stressed and feeling attacked, what's the single guiding principle that should dictate my reaction?
Well, the foundational principle is deceptively simple. It's civility and accountability. This is rooted firmly in the GMC's expectation for all doctors to promote a respectful and fair working environment. When tensions rise, your good reaction has to focus on de-escalation, on using shared facts, and separating the person from the problem.
Okay, that brings us directly to a fascinating insight the sources emphasize: the critical role of civility. This goes way beyond just, good manners, doesn't it?
It absolutely does. Civility is explicitly framed as a mandatory safety mechanism, not an optional nicety. The research on this is, well, it's very clear.
Okay, what does it show?
It shows that rude or hostile behavior measurably harms clinical performance. When someone snaps or is sarcastic, it actually reduces the cognitive bandwidth of the person on the receiving end.
Wow. So it has a direct impact.
A direct impact. It leads to delayed decisions, people withholding information, and measurable spikes in error rates. If you're discourteous, you aren't just being unpleasant. You are actively introducing risk into the patient's pathway. So protecting civility is protecting safety.
That is a powerful shift in perspective. So if we accept that errors and conflicts are going to happen, how do we handle the accountability part? This is where the concept of just culture comes in, and I know a lot of people find this confusing.
Just culture is vital, and you're right, it's often misunderstood. It's the system that allows us to look at a conflict from a mistake and ask, okay, did the individual make a simple human error because of fatigue or maybe a faulty system, or was their conduct reckless?
I think the worry for some is that just culture sounds a bit soft, that it lets people off the hook. What does the guidance say about maintaining accountability?
It clarifies that just culture is rigorous. It's not soft at all. It supports learning from errors without destroying trust, but it absolutely maintains fair accountability.
So how does that work in practice?
So if someone repeatedly skips critical checks despite being trained, that moves beyond a simple error. That's potentially reckless, and accountability has to be firm. The goal is to fix the system for normal human error, but keep robust checks against unacceptable professional conduct.
So it's about building a trusting team where people feel safe enough to report their own mistakes, knowing the system will be looked at, not just them.
Exactly. And that requires structured conversations, moving swiftly toward resolution using a protocol. We need tools that force us past the emotional part and towards a concrete plan. Using things like informal conversations or maybe even ACAS, the advisory service, before it spirals into a formal grievance.
Structure saves the day.
It really does.
Okay, let's talk structure then. This brings us to the highest scoring actions in resolving conflict, the step-by-step frameworks. If I am in a sudden disagreement with a colleague, what is that essential first, next, last sequence I should fall back on?
Okay, so the framework is designed to interrupt that emotional surge immediately. First action, relocate. You have to move the conversation to a private, calm space.
The safety move?
The safety move, exactly. It protects everyone's dignity and removes the risk of a public spectacle. Next action, you state the shared aim, something brief, non-negotiable, like, we both want safe care for Mr. K. Let's agree on facts and next steps. That aligns your purpose.
Right, it reminds you why you're there.
Then, the crux of it. You explore the facts using the SBR framework: situation, background, assessment, request, and finally, the finish. Agree clear actions, assign owners, so who's responsible, and set precise times.
Those steps are critical, but in the heat of the moment, I'm not sure I could remember all of them. which is why the mnemonics are such a powerful tool here.
Agreed. We have two key memory aids. For the comprehensive approach, there's COMPACT-T.
Okay, what's that?
It covers calm space, agree patient goal, list facts using SBR, map options, plan and owner, agree or review, capture in the notes, and trigger escalation if you need to.
And there's a simpler one too, right? Peace.
Yes, peace is the quick reference one. Private space, establish SBR facts, agree actions and owners, call for support if needed, and enter notes. Using these acronyms helps turn this from just knowledge into, well, muscle memory.
Let's be real for a moment, though. If I'm feeling challenged, angry, stressed, using a framework like SBR Day, now it's like pulling out a textbook in a firefight, how do you actually pivot to this dry, factual method when your emotions are running high?
That's the essential friction. That's precisely why SBR is so effective for de-escalation. It works because it forces both of you to stop focusing on subjective opinions and instead focus on objective data.
Okay.
What's the patient's current situation? What's the background that led to this? What's our current assessment? And crucially, what is the specific request or action needed?
So it shifts the whole conversation.
Exactly. It shifts the argument from, you are wrong to discharge the patient, to, let's review the background facts. The home assessment notes are incomplete. Request, we delay discharge until we get the full physio report.
Yeah.
It structures the fight around external information, which takes the emotional heat right out of it. It turns you into joint problem solvers, not opponents.
I see. So the structure acts as an emotional circuit breaker.
That's a perfect way to put it.
Okay, now let's flip the lens and talk about the common pitfalls. The material is very clear on trap answers, the actions that risk safety and instantly sink your score. What are the top decoy detectors we need to avoid?
These traps almost always involve prioritizing ego or avoidance over safety and structure. The single biggest trap is arguing publicly, having a loud disagreement at the bedside in a handover meeting or in the staff room.
Why is that so bad?
Because it compromises dignity, shatters patient trust, and it makes everyone within earshot lose confidence in the entire team.
And beyond the public spectacle, what about communication traps? I'm guessing personal attacks, sarcasm, that kind of thing.
Absolutely. Any personal attack, verbal or written, is a major governance failure. Also, look out for traps involving poor planning. An ambiguous plan, just saying we'll sort it out later, or agreeing to an action with no named owner or time frame, it's basically the same as doing nothing. It leaves the patient at risk.
And the escalation trap. I know avoidance is bad, but is jumping straight to escalation just as bad?
Yes. Bypassing the person you're in conflict with altogether, escalating late, or sending a critical emotional email to a manager without first trying a calm conversation, that's a low-scoring option. Structured, face-to-face resolution is always the preference. Public arguments, email blame storms, or just avoiding it. They all fail because they put personal emotion over the factual management of risk.
We need to make this feel practical. Can you give us some specific phrases we can use to activate this framework when we feel that tension rising?
Yeah.
How do I start that private relocation without sounding, aggressive or awkward?
You use that shared patient-centered goal as your shield. You initiate it by saying something like, let's step aside for 2 minutes. I want to make sure we're aligned for the patient's safety before we proceed. The phrasing makes it clear that the patient, not the conflict, is the priority.
That's really empowering. It removes the personal confrontation bit. And once you've used SBR and agreed on a path forward, how do you lock down the resolution with accountability?
With tight ownership and time frames, you confirm it out loud. So we agree, you will call CT by 11:30, I will update the family at 12:00, and we'll regroup at 12:30 to confirm the plan. It's a tight, accountable resolution that restores workflow and reduces any future ambiguity.
And this leads us to the final piece, right? The mandate for documentation and escalation.
Exactly, the final component of that structured response.
So what precisely has to be recorded after one of these disagreements?
Well, factual documentation is non-negotiable. For accountability and for continuity, you have to record the facts agreed upon, the specific actions, the owners, the timelines, any escalation that was made, and most critically, any impact the disagreement had or could have had on patient care.
And the classic FAQ. When do I escalate? When is it time to move beyond that local 2-minute chat?
The rule is clear. You escalate immediately when patient safety, dignity, or workflow is still at risk, or when local resolution has been tried and it's demonstrably failed. And crucially, the escalation has to be proportionate and factual. You brief the senior or manager using SBAR, fact situation, background assessment. You avoid personal feelings or blame. You brief facts, not feelings.
Let's put this all together with a high-stakes scenario. Let's say you're about to discharge Mr. K, but a senior physiotherapist challenges your plan loudly in the hallway. They say the home environment is unsafe, they refuse to sign off, and the patient hears everything. What do you do?
The ranking logic here forces us to intervene immediately and privately. The highest scoring option is always the one that follows the framework. You first thank them, move to a quiet space, restate the shared aim of patient safety,
Right.
exchange SBR facts on the home assessment, agree on clear actions like calling the social worker, update the patient with a unified message, and then document the disagreement and the resolution.
And the worst options are pretty obvious, but I suppose tempting. Ignoring them and discharging anyway.
Which is unsafe.
Or immediately insisting you're the most senior clinician and overruling them publicly.
And those actions tank the score. They destroy civility and they risk unsafe care. The core message is reinforced again and again. Private, respectful discussion focused on evidence and patient safety always wins over public rows or unsafe discharge. It shows you embody the principles of a just culture.
So what does this all mean for you, the listener, in your day-to-day practice? Let's crystallize the 3 core takeaways from all this.
First, private, patient-centered de-escalation must always come before a public argument. If you feel tension, activate that relocation step immediately.
Second, use structured tools like SBR to make sure facts come before opinions or blame. Structure is your emotional circuit breaker.
And third, every disagreement that impacts care requires you to agree on actions, assign owners, set timelines, and then ensure your documentation is factual and escalation is proportionate.
That is a clean, actionable playbook for managing the most difficult professional moments.
And that's the long-term impact we want you to think about. While using this kind of structured conflict management, it can feel difficult in the moment. It feels time-consuming. But consistently applying a just culture mindset and ensuring civility is the most reliable way to build a high-performing, safe team environment. Think about how these structured conversations fundamentally change the safety culture around you, making critical thinking safe for everyone, no matter their hierarchy, for years to come.